Connections Commons Conference. I'm Phaedra Pezzullo, a professor of environmental communication and cultural studies here at IU, and I have the wonderful honor of introducing our keynote speaker. I think it was basically a game of hot potato where everyone else was too intimidated to do it in 5 minutes, but I'm going to try the challenge. By way of introduction, I want to first provide an overview of his scholarly record, not just due to the ritual that this provides, but also to underscore his impressive credentials. As the dean said this morning, I too often find that once one identifies as someone who is marginalized or becomes closely associated with marginalized voices through service learning, applied scholarship, or other labels, some too often assume that we're not serious scholars. And our speaker today delightfully explodes that stereotype. He holds a Bachelor of Technology in Agricultural Engineering from the Indian Institute of Technology and a PhD in Mass Communication from the University of Minnesota. He worked from 2001 until 2009 at Purdue University, which we'll forgive him for today, in part as an Associate Dean of Research in the College of Liberal Arts, and he retains a courtesy professorship there. He currently is the Provost Chair, Professor, and Head of the Department of Communications and New Media at the National University of Singapore. He also is the founding director of the Center for the Culture-Centered Approach to Research and Evaluation. And if you've not visited his website, I highly encourage you to do so. It's www.culturecenteredapproach.com, all is one word. And there you can see a full list of his publications and performances in health, culture, structure, and agency, as well as links to stay in touch via Twitter and Facebook. A seemingly tireless scholar, he has published over 170 journal articles and book chapters, as well as 3 co-edited books, Emerging Perspectives in Health Communication, Communicating for Social Impact, and Communicating Health Disparities. His single-authored books, Communicating Health, Voices of Resistance, and Communicating Social Change, invite us to consider nothing short of a revolutionary transformation in how many imagine and plan health communication campaigns and projects. In recognition of his achievements, he has won numerous awards, including being recognized as the Louis Donahue Outstanding Scholar in Health Communication, as well as both undergraduate and graduate teaching awards. He also serves as editor of the Critical Cultural Studies and Global Health Communication book series with Left Coast Press and sits on the editorial board of 7 journals. Our keynote also has received millions in funding for his health communication and advocacy work globally. In Indiana, he received a $1.5 million grant funded by the Agency for Healthcare Research and Quality to develop a project on heart disease with African American communities in the Lake and Marion counties of Indiana. More recently, for those of you who follow him on Facebook as I do, he's begun to share an exemplary campaign that embodies his approach to research and is animated by voices and rights of domestic workers in Singapore. With that overview of line items that you could read more or less on his vita, I want to say a few things about his conceptual value to me, and I'm sure to many of you in this room. Throughout his publications and projects, our keynote speaker challenges dominant health communication perspectives by promoting a culture-centered approach to health. By this, he reminds us how our perceptions of health, illness, messages, and treatment are shaped by our dynamic local and global cultural contexts. In doing so, he reminds us to listen to marginalized voices if we are invested in helping foster a healthier world. His own research has been informed by voices of indigenous communities, sex workers, migrant workers, rural communities, and communities living in extreme poverty. Tracing his own awareness of advocacy back to when he was a child, I appreciate when he shares this story, and I wasn't sure he was going to do it today, so I'm going to do it for him, when he recalls asking his uncle, a trade union leader in his hometown, if he could help out when he was only 3 years old. As he notes, quote, "My socially engaged joint family of political leaders and trade unionists taught me to believe in social change and to work for it. My father taught me the value of activism and of the intersections between academe and the politics of change. The abject poverty and the struggles of my people taught me that intellectual exchange is incomplete without engaging the real struggles of real people." End quote. For many of us, especially those of us who have grown up poor and or served as parts of grassroots community groups and partnerships, his approach might seem obvious. Our experiences and research such as his shows time and time again that contextually based, co-constructed health campaigns are more meaningful, more successful, and more sustainable than alternatives. Certainly Eleanor Ostrom knew this to be true. Certainly Mayor Mark Krzan and our community advocates here today know this to be true. Yet we live in a time in U.S. history, as a recent Princeton study confirmed, not of a democracy, but of an oligarchy, where the wealthy rule. As such, we know there are countless pressures from funding agencies, university administrators, and more to promote a top-down agenda that pursues profits over experimental research, short-term results over long-term dialogue, new brands over ancient traditions, paying for healthcare consulting firms over listening to local expertise, and resilience planning over prevention through structural transformation. So as we engage in dialogue here today, I hope we'll consider both how to strengthen our ties internally and to stand in solidarity to collaborate when the day is done. With someone so prolific and as engaged in praxis globally, the only comfort I take in my brief introduction is that it ends with all of us sharing the opportunity to listen to him in person. So please join me in welcoming one of the kindest, smartest, most generative and imaginative scholars I know, Professor Mohan Dutta.
Thank you so much, Phaedra, for that introduction. And what you really do is humble me through that introduction. And I'm not sure if I'll be able to follow that introduction, actually. Phaedra's own work with environmental communication is an invitation to this logic, to thinking about how we can imagine the world in new ways. I would like to begin also by thanking Joan for her relentless pursuit in trying to get me here. What had happened is we had gotten in touch in 2011, and I was still at Purdue at that point, trying to make the move to Singapore. And she said, would you come over? And we had both thought at that point that it was going to be a short trip. And pretty soon, it ended up being that it's going to be a 24-hour trip. And we had to work through multiple exchanges over the last 2 years to finally make this possible. So thank you, Joan. Thank you also to IU and to the work of Eleanor Ostrom. As Phaedra mentioned, thank you for giving my Boilermaker rules for one day, and I hope that we can engage some points of conversation that demonstrate the linkages that I hope to bring to the point that there are issues in Indiana that connect us together, and that I think need to be explored broadly as a state, and I will highlight those. I will begin my talk by first thanking the many activists that I've had the chance to learn with and learn from, who have given me the humility and also the knowledge in knowing the limits of my own work. As I do so, I want to particularly mention Indiana Minority Health Coalition, Northwest Indiana Health Disparities Initiative, and Black Caucus in Indiana that I've had the opportunity to learn from and work with over the last decade, when I spent my time at Purdue. Today I position my talk as communication and spaces of structural transformation, collaborating for alternative imaginations. What I hope to highlight is this idea of alternative imaginations and really hit home a few key points about why we need to foster spaces for alternative imaginations. As I do so, I hope that you will see throughout my talk threads that are inspired by the Ostrom workshop and by the work of Eleanor Ostrom, and the notion of the commons, but also the notion of the enclosure of the commons and the privatization of the commons. So I begin with this notion that I hope to embed throughout my talk is that health is a fundamental human right. Health is a right that belongs in the realm of the commons. So I position my talk within this sense, looking at the ways in which health has been enclosed, the ways in which health has been turned into a private commodity. Even as, and I spent, my last part of time at Purdue, I spent doing quite a bit of work on the Affordable Care Act as it was getting ready to be launched. And one of the things, looking back, I feel like it's a necessary commentary, is that even as we look at moving toward universal access, moving toward having more people covered by health insurance, we still have a system that is dominated by managed care, insurance agencies, and pharmaceutical companies. And hefty salaries that doctors take that is unregulated. So, when I really talk about health within this setting, I also suggest this notion of rethinking how we come to organize and constitute health. Hence the notion of spaces of structural transformation. So I will begin by talking about the structural patterns of health and really looking at the ways in which health is structured in society. Then I will move from there to set up the argument for transformations and why do we need to imagine a world where transformations are not only relevant but the need of the hour. Then I will talk about how communication is constituted amidst cultural structures, and then use that as a basis to discuss spaces for alternative imaginations through 4 key elements: collaborations, dialogues, participation, and listening. And then finally, I hope that some of the points I will bring through, drawing upon my own work over the last decade of academic community partnerships that might be relevant to very interesting work that you're doing, which is the notion of power as it relates to academics, civil society organizations, and non-profits and communities. So let's begin by looking at the social structures of health today. The images that you see on my screen are not simply images in Brazil, Venezuela, India, or Bangladesh. These are also images of the UK, the US, parts of Canada, Singapore. Poverty is not a third world problem like we would have to want to imagine, but poverty is a problem that we sit amidst. In Singapore, for instance, where we talk about growth, economic development, and a technologically enabled nation state, I'm struck by the extent to which poverty remains incipient, sustained, and an intrinsic part of the system, albeit hidden. As a communicator, therefore, I'm also struck by the extent to which the ways in which we participate in communication every day works to hide the poverty that exists amid us. So the health challenges that we face today are constituted amidst the large-scale global inequalities that we witness across the globe. And again, when we look at the data, this is not only within nation states, but also when we compare nation states. Of course, within the US, starting in 2008 up until now, you have started noticing some of these dramatic nature of inequalities. I again remember and refer back to my work with Voices of Hunger projects across communities in Indiana, and one of the things that would come out of these projects is how deep-rooted poverty seemed to be, but also how transitory our access to resources seemed to be, meaning that a family that would have access to a decent standard of living one day could be within 3 months out on the streets without any social infrastructure. So intrinsic to the notion of inequalities also are the vulnerabilities that are constituted globally. So these also then relate to entrenched patterns of health inequalities. Inequalities in distribution of health resources. And here I'm not really talking about inequalities of access to care, but I suggest that we need to look broadly in terms of defining health. In the context of inequalities in access to schooling, inequalities in access to safe and clean environments, inequalities in access to safe and clean food, inequalities in access to spaces to play, to share, and to create culture. So inequalities of health, when we think about these broadly, are also inequalities that I suggest are rooted in structures, meaning if you look at the US landscape, there is a large body of research on addressing health inequalities and disparities within the US. I just wrapped up editing a book on communicating health disparities that Pedro was mentioning. And one of the things that you see in that dominant body of literature is that we address health inequalities by telling people to eat healthy. by telling people to exercise, eat 5 servings of fruits and vegetables, it will prevent cancer. And that dominant logic of addressing health inequalities often obfuscates or erases the fact that health inequalities are fundamentally structurally rooted. So you really are not addressing the pie at all, any part of the pie, if you limit your intervention or your communication to telling people eat 5 servings of fruits and vegetables. I've seen this in Gary, Indiana. It's really stupid and in some ways harmful to the local people. If you're going into an underserved African American community with a campaign of splashy advertising that's telling people, oh look, these beautiful fruits and vegetables, you should eat them. There is no conversation of food deserts, inequalities of access to food, the number of fast food restaurants and how those restaurants need to be regulated, how agriculture has been privatized and access to food has been privatized. So these conversations we are not having. Instead, we are sticking ourselves to reformist conversations on individual behavior change that really don't do much in terms of addressing the broader structure. So within all of this, we see increasing impoverishment of the poorer sectors of the globe. So as a health communicator who has been working on this, one of the things that is very humbling to me is how ineffective we have been for the millions of dollars that have actually been pumped into running health communication campaigns. I did some of my earliest work with WHO campaigns with underserved communities in India, and I would really be struck by how small the effect sizes would be, right? That you go into a community, you spend large sums of money running a campaign, and then you see that the effects that you're seeking in the community are not really there a whole lot, and even when they are there, they are gone. So what is our typical response when we see that? We look at it and we say, these people are primitive, they are backward, they have some cultural problems, that's why they're not adapting the good behaviors that we are asking them to adapt. In that process, we completely miss out on people's voices, their narratives, their own understandings, but also, I would say, how we ourselves profit from this industry of poverty. In many instances, might I be so bold as to suggest that poverty itself or health for the poor itself has become an industry where we can get our grants, where we can get our funding, we can be stuck to writing up reports for the funding agencies that are supporting us, and that becomes a business. So, there's a culture, for instance, of report writing that civil society organizations or academics like myself participated, where we are more interested in presenting a glossy report that would satisfy our funder than in really what is going on in the community and what are the community voices articulating. I then go to this point then that the overall structure in addressing issues of poverty and health is a very simplistic narrative that when you have more growth, when you have more enclosures, more privatization of what are in the commons, you would have greater development which would address issues of poverty and inaccess. In spite of building evidence across communities in the global south, but south within the north, where this is not held to be true, where you actually see empirical evidence that really questions this logic, this continues to be the dominant logic under which we operate. Within this broader system, then we notice healthcare structures and public health infrastructures that are increasingly being weakened by narratives of privatization. So, one of the things I do as part of my work is follow consulting reports, that are issued by big consulting firms like McKinsey. These consulting reports are really interesting because you see where sort of the economy of knowledge is moving in terms of the kinds of recommendations that these large firms make toward the kinds of organizing we want to see in the society, right? And within many of these consulting reports, a narrative of health seems to be a very simple narrative that the state or the public infrastructures are weak, they're inefficient, they are corrupt. So these studies typically tend to point toward that. So the solution they bring is let's try to privatize. That's the implicit solution in it. In spite again of the evidence to the contrary that documents again and again that it is the weakening fundamentally of public health infrastructures that has led to many of the problems that we sit amidst. You think of Ebola, as a crisis that we are looking at right now, and then you look at the ways in which West Africa has been gutted Its public health infrastructure has been gutted by World Bank and WHO-led structural adjustment programs. And then you start really seeing what does it mean when we pay attention to this logic of privatization of healthcare as a solution. Along with this, then there is weakening of integrated primary healthcare delivery infrastructures. So this is something that is often done in the narrative of increasing access, meaning, and this it is when you find or identify an underserved community. Let's take the African American community in Gambia, and let's say that we want to address their health needs better. So what is the solution? Let's privatize. So that we can address their health needs better. In spite of the evidence that again documents that these models of privatizing actually limit access to fundamental forms of healthcare. Within this backdrop, there is another set of problems that I want to introduce, which is the problem of the increasing displacement of the global poor. Again, whether it is inner city Chicago or whether it is indigenous communities in India, you see the poor increasingly being threatened to be displaced from their spaces of livelihood, often in the name of development programs and programs of health, delivery of, or of economic growth. So in these images that you have here, for instance, in the extreme left you have an image of a bulldozer. And then you have a group of community members sitting in front of the bulldozer. This to me has become the fundamental image of health when I look at many of the communities in the global south that I work with, which is that communities are increasingly being threatened to be displaced from their sources of livelihood and from what they understand to be health. And that is often done in the name of mining projects. That is often being done in the name of oil and gas exploration projects. That is often being done in the name of water privatization projects in order to increase, or the languages that we are actually trying to increase greater access to water. Let's privatize it. And you have companies like Nestle that are playing in this game. And I think this is really where the problem of health lies. So in some ways, the argument I'm placing for you in Bloomington is that your health in Bloomington is not different from or not separated from the health of the people in Kalahandi in Orissa in India, or the health of the people in parts of West Africa, or the health of the people in Latin America. And if you sort of look at the broad narrative, if you look at, for instance, the narratives of fracking and the fracking industry, if you look at the narratives of the mining industry, all of this narrative is constituted under this notion of better development, better economic growth, which would bring about health. But fundamentally, these are forms of economic performance and production that threaten the essence of health and well-being. So the irony, I hope, here is evident. So health in this sense for me is interrelated within broader contexts of sources of livelihood, threats to the environment, weakening of labor policies and labor rights, and the corporatization and privatization of agriculture. So the overarching communicative interpretations within the grand narrative or the grand story of development is that modernization and progress would bring about development with what I say is a technology fetish, which is that there is an app for solving every problem and there is an app for solving poverty. Again, when I'll give you examples throughout my talk. When I sit at forums with NGOs, for instance, sometimes I'm just amazed at the arrogance of NGOs and civil society organizations that will believe that, hey, I can sit here in Boston and create an app that will solve poverty in Bangladesh. And you have people like that. And when you start digging deeper into this narrative, asking questions such as, hey, have you traveled to Bangladesh? Do you know Bengali? The answers typically are no, but for this entire coterie or industry of practitioners, these are not really important issues or questions. The community or understanding the community is not really the question. To the extent you can have an app, you can solve the problem that comes with it. And within this context, then there is an interplay of state and transnational corporate interests, particularly in the ways in which the state agendas are being gutted to serve transnational corporations. But along with that, I might suggest academic institutions as well. So if I think about, Purdue, and when you consider the number of endowed chairs that are funded at Purdue by Monsanto and Dow Chemicals and these large agrochemical businesses, it is amazing. So within that setting, we also, and I think Federer really posed this important question, we have to also ask the question, what are academics doing? Whom are we serving? What is the nature of academia as it is becoming today? And how is it positioned within this context of relationships between state, civil society, and market? And even more importantly, and this is, I think, again, a key point to theorize about, it is the deployment of the military to enable the consolidation of resources in the name of development, progress, growth, and security. Again, be it in Ferguson or be it in Kalahandi, Orissa, you see incredible investments in the police and in the militarization of the police, so that the police no longer looks like a local police, but it looks like more of a well-endowed military machine. And that, to me, is a fundamental threat to health. So what I'm trying to pose here is that health communication and communicating about health is an integration of all of these issues. And when I sort of think about it, I think how dwarfed I feel when one starts really paying attention to the interlinkages. So it is no longer about telling an underserved African American community, go take a walk in the park for 15 minutes a day. It becomes much more complex, and I think we as academics become much less competent at handling and addressing these interlinkages and intersections. So communication in a modern world, and now go back to setting up to what is the broader framework of communication and then move to the argument for transformation. So communication in a modern world is seen as an intersection of democracy that is married to capitalism, tied to the logics of science and technology. So this is going back to the earliest of communication theories that believe that if you bring more television or more radio sets into the poor communities in Africa or in the Middle East, these will become developed communities, right? So these were some of the earliest forms of communication, which is that you bring the communication technology, and today we can talk about bringing Facebook or Twitter into a community, and somehow that would empower the community. And you see this in the narrative of the Arab Spring, for instance. The overarching narrative is that you introduce Facebook into a community and boom, they found democracy. While really, if you attend to the logics of local context, it's much more complex than that. There were local trade union movements, there were local participatory processes, there were lack of access to bread and food. These are the kinds of things that were going on locally. So within this logic, then communication is seen as a linear flow of packaged information from sender to receiver. So the sender sends a message to a recipient. Communication is dissemination of information. So you create more information, and that would build the infrastructure. So if you think about this broadly, this is also a narrative for building health infrastructure. So when you think about building a health website, this is often also based on this logic that if you build access to the right kind of information, we have done our job in terms of building a communication resource. Or the other kind of framework is a framework of persuasion that argues that only if we can persuade people by maybe making them frightened that, hey, if you don't eat 5 servings of fruits and vegetables, you might have cancer, or by making them feel a certain kind of affinity for things like fruits and vegetables, that we will be able to change their behaviors. So new communication technologies in this sense are magic bullets of development. This is age-old communication theory, the hypodermic needle model, right? So communication is like the magic potion. You take it, put it in a syringe and inject it, and your target audience will be changed or transformed. Unfortunately, even though this model has been debunked over the last 3 decades, and there has been a lot of conversation and critique of this, this continues to be the dominant model or dominant framework of communication. So even when we think about building, for instance, health websites, health resources, our framework still continues to embody this notion that you give people the message and they will change. So within health communication in new and emerging media, we think about usually 4 kinds of communication action. One is discovering the next new technology for behavior change promotion. So I'm in a single code that has 75% penetration penetration of the internet, so it is a very digitally enabled city. So I'm enamored by how your policymakers, politicians, and it's a pretty progressive city in many ways, are continually obsessed with this notion, what's going to be the next app? What's going to be the next Fitbit? What's going to be the next smart technology that's going to enable us to gain greater access to our target audience and actually enable them to engage in behavior change? The next is, how do we deliver information through new media? Again, with an information focus, how do we create new media platforms that enable us to deliver more information? And this includes information that is often covered by Right to Information Act or Freedom of Information Act. So, I do not want to, of course, delegitimize the amazing work that is done by activists trying to get us access to information about policy processes and decision-making processes. Having said that, I'm also struck by the argument that Jody Dean makes that we live amidst information capitalism, where even information that is critical of the state or the state-corporate nexus, if you think about, the NSA revelations, for instance, in terms of the state monitoring us so closely, once we have access to that information, which most of us do, what do? Nothing. Right? And that is the seduction of information capitalism, where you think that you have access to information, you have access to Facebook and Twitter, you're gaining access to new kinds of information that you think are transformative because they're rendering these systems transparent, and yet they are limiting us in terms of our capacity to act. So that's something I'm very aware of as well. The third kind of element is leveraging social networks or new media to persuade. And the fourth element is discovering the most effective message strategies for dissemination via new media. So there are some key assumptions that play out within these kinds of messaging strategies that are information driven. First is that there is a normative idea in public policy and programs that information holds the key. And we need to challenge this normative idea. We also need to interrogate what our taken for granted values are about information communication and their relationships to society. We also need to question taken for granted assumptions about growth, grounded in four key ideas. One is more consumption. So again, when we think about human health, and we see solutions of health being offered as more consumption, right? So you consume these new products. If you think about the obesity epidemic, for instance, that's a great example. We just wrapped up a study that's an analysis of The Biggest Loser. Pretty good example. I think it's a messaging strategy that is directed at addressing weight and obesity, and yet one of the things we find, and this is again not particularly specific to our group, there are other scholars like Helen Schubert who have found these similar kinds of linkages, which is that obesity is addressed through media by selling more products that are directed at handling obesity. So you have your gym, you have your apps, you have your healthy food products. So the cycle of consumption, of course, continues. So in that sense, if you think about it within this logic, we as subjects and as individuals have to keep consuming more and more if we want to be healthy. There is something wrong in that logic. One of the things that I work more, a lot of my early work was with indigenous communities in India. It's a community of Santalis, and one of the things I learned from this community was this notion of questioning the whole assumption about consumption. Because for this community, health meant being in harmony or living in harmony with nature. So when I would ask them a very simple question, often I began my ethnographic work with a simple question: what does health mean to you? They would say, health means for me to live in harmony with these trees that I'm surrounded by. And then you look at all these projects that are cutting down the trees. That's where I think that my health is gone, because the spirits that live in these trees protect my health. Now, I would present this ethnographic work among doctors or practitioners, and they would ask me, you could not possibly believe in this, right? You could not possibly believe in this hocus pocus that spirits live in trees and that's what makes someone healthy. And my question to them would be, why not? Is it not hocus pocus when you want to give a pill and say that that is going to solve one's health problem? So what makes science and the technology of science and modernity legitimate is a fundamental question I think we need to be asking, particularly as it relates to understandings of communities. So when I look at Ostrom's earlier work, and I see some of our work that comes out of India, studying communities in India that lived in this kind of a space of spiritual harmony with nature, protecting their trees, really embodying the idea of commons, right? And something that teaches me is, for instance, the idea of commons is not something, again, we take and use a magic bullet to train communities. In fact, many indigenous communities across the globe, as Ostrom's work suggests, already know very well to live in the commons, to manage the commons, and to respect the commons. So questioning more consumption, also questioning the notion of individualism. So health is often given to us as an individual level solution. So if I enact good behaviors, if I take preventive behaviors and I get my screening done, I will be more healthy. So if you look at, for instance, the entire body of work on cancer communication, it's a powerful body of work because it points to dramatic inequalities in cancer and looks at communicative inequalities as they relate to cancer. But again, this body of work will not touch upon things like cancer clusters. Will not touch upon things like the radioactive sites that are left open by corporations that are operating unethically within local contexts, will not touch upon environmental regulations as they relate to cancer. So in that sense, the logic of individualism also works precisely to perpetuate the erasure of questions of structure and violence, and of the violence to health and the environment that are being done by contemporary sets of institutional structures. The third element is the element of greed. Once again, if you look at the broader context of poverty, inequality, greed emerges as an important theme, and yet it remains a theme that remains unaddressed in much of the way in which we talk about health communication. And again, finally, the notion of self-enhancement, the basic idea that individual human beings are self-enhancing agents, which is in some ways a very Western, very American notion, but also a very particular kind of American notion. And we try to mirror that on communities across the globe. So we miss out on this notion that individuals can actually be community enhancing, individuals can actually be harmonizing, individuals can actually be relationship seeking. And if we sort of move toward these kinds of fundamental ideas of what an individual is, what a human being is, what human life is, I think they would take us to different kinds of understanding of health and healing processes. So alternative imaginations then suggests the question, what are we missing out when we think about health as an individual commodity, when we think about health as a consumer product? So it suggests that we need to first think about communities as spaces of imagination. So, my question for you in Bloomington is, what is this space of imagination that you're creating when you think about health and well-being? Values grounded in organic and continually shifting community networks of care. So thinking of communities as networks of care, it's an interesting way of approaching the notion of the community. Communities as resources for problem identification and development of solutions. So in much of the work that I have done, I've been struck by this very simple idea that in many instances, communities themselves know how to address their problems. They don't need experts like me. But then I'm out of a job. Because I've made my living, my promotion and tenure dossier and my vita on turning communities as spaces where I could go and tell them something meaningful. So this is a very powerful notion that communities themselves, when enabled, can identify their own problems and develop their own solutions. We also need to look at communities and the ways in which they relate to nature, the ways in which they relate to economics, and the ways in which they relate to struggles of everyday living. And then finally, we need to look at communities as sites of organic norms that are always dynamic, that are always shifting. Within this sense then, when you talk about the poor and the marginalized in any community, you have to be, and I have to be aware of the language that I am using and that you're using to mark the poor and the marginalized in some kind of deficit model. as if they don't have something, and they need you and me to come in as the bourgeois middle-class experts to go in and give them solutions. And really be attentive to the political economy of this kind of structure, in a sense, really ask who benefits from this kind of model, right? Because when you place the community as a deficit, that creates a need for people like you and me, so we can actually go and earn our bread and butter. To think about communities as spaces that come up with their own solutions also then would suggest that we start respecting communities and their fundamental communicative dignity. So communicative dignity is essential, which suggests that every community has a dignity and a sense to understand the world and the problems in the world that it lives amid, and to come up with solutions as constituted within this world. So the first kind of element that I will talk about when I talk about alternative imaginations communicatively is about creating communication networks as structures of story or persuasion to storytelling. What are the stories we tell? You know, the work of my colleague Barbara Sharp is amazing when you think about health communication, because she suggests that the one way to inverting doctor-patient relationships, for instance, and the enormous power differences in those relationships is by starting to think about communication in that setting as storytelling. That the doctors tell a particular kind of stories, patients tell a particular kind of story. So how can patient stories be enabled within those contexts? Spaces for integrating new and traditional communication channels into an integrated network for the sharing of alternative stories and rationalities. In this sense, then, technologies are situated within broader structures and structural pattern of distribution of resources. Again, a lot of what I share is from my own failures. So, again, one of the early projects I had worked on was on the digital divide, with the idea that you work with a very low-income community and train them digitally how to become more enabled, with the idea that they would participate in this cyber infrastructure. What we found is amazing. The members from within the community that participated in the technology were the elites in the community. So the low-income, marginalized people from within the community, they never participated in that technological platform that we had created. And this was after, working with the community, doing ethnographic research, having the community suggest communication platforms to build, and it still didn't work, particularly with the very disenfranchised. Can you tell me why? It was actually pretty simple. For someone that is struggling to keep a job or find a job, for someone that is struggling to find food, for someone that is struggling to find transportation to get to places where they could get food, and we did a kind of resource mapping of the city, and found, for instance, that only if we could create a communication pathway, right? So you take this bus, on Monday you can go to this food site and food pantry and pick up food. On Wednesday you need to walk to this station, then go to this bus, and then change another bus, and then you can get to, and we thought that all of this would work. Why? For people that had everyday contingencies to fight with and struggle with, going to a technologically enabled platform was not the solution. They were not going to go find a kiosk or a computer platform somewhere, then hook onto the internet, then read, go to that website and then find out how to go and then map it out. Didn't work. So that was pretty telling in terms of our approach to technology when we think of technology as solution, right? And this is, you look at JAMA, you look at American Journal of Public Health, this is sort of the broad discourse, which is cyber infrastructure will solve inequality and problems of inaccess. And my response to that is that cyber infrastructure, without addressing economic infrastructures and structural inequities, is not going to solve problems. And certainly, and this is actually, for a communication scholar to say this, I think it is kind of paradoxical, because what I'm saying is that communication technology is not the solution to broader inequalities, but rather rethinking of communication as a way to fundamentally change those inequalities needs to be the starting point. So I talk about democratizing communication and new media. So of course, the first two elements are covered in much of the digital literacy and e-health research. One is to build communication as resources for information, where you, for instance, give people information objects, or you point people to resources that you build in, or you tell people how to access resources. This is the predominant body of work. Then we talk about communication as resources for collaboration in terms of building partnerships that are enabled by new technologies, peer-to-peer networks, networks that give us access to policymakers, and also create local global networks. But I will add another layer on top of this, which is communication as resources for listening and storytelling, to creating spaces for communities to share their stories that resist marginalizing policies and structures. Now, this is something that our funding agencies or state or federal agencies or foundations might not be interested in, because these stories might be too inconvenient. So the question for you then is that if you truly care about health, how do you build these kinds of infrastructures for these kinds of storytelling? Let me give you an example from our work in Gary. In the early part of our work in Gary, a number of African American community members started coming up with this idea, and this was a project on heart health, that for African Americans and questions of heart health, one of the key issues is racism, and the ways in which racism produces stress in the community, meaning lack of access to jobs, the everyday racism that you face when you simply walk into a Walmart and you feel like you're being followed, the racism that you experience in not being able to access educational systems. But that kind of a narrative is an inconvenient narrative. And what we found is that that kind of narrative, even the elite community members from within that community were not willing to tell, because they wanted to craft a different kind of story about the African American community, right? So you also have to think about this question: what is a community when you are creating these community infrastructures? Is your NGO a community? Who are your NGO representatives? So we do a lot of work with advisory boards. We put together advisory boards, and lo and behold, what we find that is that in our advisory boards we will have members that are university educated, technologically savvy, have access to technologies, not your marginalized and disenfranchised community members. So this question, community is not a monolith, and let's not be confused thinking that our NGO partners somehow become communities. Similarly, let's not be confused about our own privileges as academics within those settings. So resources for storytelling, stories for activating social change and structural transformation. So what are the kinds of stories that will actually enable structural transformation in these communities? And what are the kinds of stories that will mobilize resources? So now I will present a couple of examples from my own work. This is a project that is done with women farmers in Andhra Pradesh in India. So Andhra Pradesh, if any of you were to follow news, has been in the headlines, particularly in the agrarian communities, because of the large-scale farmer suicides that are taking place within these communities. Of course, I'm going to present you a linear narrative, and there are ways of looking at that narrative in other standpoints as well. But the linear narrative is that the state started sponsoring BT cotton. I don't know how many of you are familiar with BT cotton. BT cotton is a biotechnology-induced strain of cotton that's supposed to be more pest-resistant and productive. It's a strand of cotton that is produced by Monsanto, and that was introduced in these farming communities. And this is sort of in the backdrop of the Green Revolution and how Green Revolution contributes to community health. Now, one of the things that started happening in these communities is indeed productivity went up, and productivity was very high for your large-scale farmers that had the money to invest in the technology and resources. But for small-holding farmers, they needed to actually take out debt and take out loans in order to get the technology. So when there was crop failure for one crop cycle, the farmer went into additional debt. Without being able to handle the debt, many farmers commit suicide by simply consuming quite ironically, by simply consuming the very pesticides and fertilizers that they have bought from the company. So within this context, the women farmers came together to say, we are going to redefine health. This is a very good example of a community project. And they said, we are going to redefine health by taking ownership of our own agriculture. Meaning that we are going to prevent agriculture from being corporatized in the hands of a transnational corporation, and from the seed being corporatized so that it is no longer in our control. So one of the things that happened with the movement to cash crops and movement to biotechnology-driven agriculture in these communities was that the seeds had to be actually bought from the market, as opposed to traditional community norms of passing the seed from generation to generation. So there you go, a great idea of the seeds as the commons, right? The seeds as the property of the commons. So they said that we are going to take this back. So we are going to fight, and I think this is really telling in terms of how you resist enclosures. And they said we are going to fight this back by re-articulating the seed as a source of life and a source of health and well-being. So a seed cannot be owned by a transnational corporation, a seed cannot be sold in the market, and a seed cannot be sold to us by anybody else, because the seed is ours to keep. Okay? So this became the basis for multiple agrarian movements that you're now seeing across India, across Bangladesh, that are fighting Monsanto in the courtroom. And they're fighting Monsanto on the claims of biopiracy, arguing that when Monsanto comes in, takes the BT gene and introduces it to brinjal or eggplant, for instance, which has many different varieties in India or in Bangladesh, it is actually stealing the local knowledge and the local germplasm and introducing it as a private commodity. So the fight in the court then is a fight for ownership of this knowledge, which is that the knowledge of eggplant and the growing of eggplant is a knowledge that belongs to indigenous communities. It certainly doesn't belong to Monsanto. And within that context, the idea of enacting health is the idea of taking back the commons. So communication as a site of storytelling in this example becomes the notion of communication as a way of understanding alternative imaginations. In this context, the understanding of seed as another kind of imagination. The stories that emerge from communities offer invitations for other stories at local, national, global levels. So this, I think, is a challenge of communication and building communication networks, which is how then does the story of these women farmers in India connect with stories of farmers in Indiana who are facing many of the similar struggles. How many of you have heard of agricultural site contamination, where a farmer has their agricultural site contaminated, the Monsanto person comes in, says, hey, you have stolen our seed, but the site simply happened to be contaminated because of wind blow, right? And then actually takes the farmer to court. And this becomes a strategy for monopolizing agriculture. So what do the women farmers have to teach here? What do the farmers in Indiana have to teach the women farmers? And I think there are many important stories and strategies for resistance that are really important that emerge from this. So community members take ownership of these stories and they partner with relevant organizations to circulate these stories. This is another example you see here. The women farmers, they do not need our PowerPoint charts and specialized apps. We are not giving them any technology to do anything, right? They have come up with this in terms of figuring out how to plant in their community and what kind of crop cycle to use. And what you see there is that they have different rocks that are placed. So they have taken their community land, divided it, and then the rocks signify different kinds of seeds that they are going to grow. And simply with rocks, they have created a community plan about how they are going to grow things in the community. So this is a great example about what nature has to offer to us. When we think about our relationship in harmony with nature, and within that context again, making us question, do we need new technologies? Do we need new apps? I'm just amazed that, for instance, in many of these communities, how social entrepreneurs will come in and say, hey, I have a new app, we can start using this, and what you're doing, we can now scale it onto this new app. My question is, why do we need you? And why does the community need you? And why would anyone pay for this when This can be done like this. It's similar to using Prezi and PowerPoint, you know what I'm doing right now, as opposed to using the blackboard as a method of teaching, right? So we also have to think about our relationships with these technologies. Also, thinking about communication as solidarity, which is working collaboratively with each other. But the notion of solidarity is also about this idea of representation. I go back to the work of Gayatri Spivak, who says that to imagine that you are representing a community itself is an act of violence. To think that somehow by working with the community, being a community organizer, for instance, that you step into the shoes of the marginalized and you become the marginalized is an act of violence, because what you and I have essentially done is erased the agentic capacity of the community to articulate its own views. So understanding solidarity as a work of working collaboratively is also about giving the dignity back to communities that we have often taken from them. Partnerships between academics and communities need to be thought through in terms of relationships of power. These are not neutral sites. You know, when I reflect back upon, again, my own work, I think about the ways in which I embody power. Who does the budgeting? Who holds access to the resources? Who is funding the community organizer? Who is setting up how measurement and metrics are going to be done? You know, so when I'm running a community intervention that is built as a randomized controlled trial, I need particular measures at the end. Who determines what those measures are going to be? Similarly, within the community setting, when you have a community partner, as I said, the community partner is not equal to the community. What kinds of representations then are being put forth by the community partner? What channels actually respond to community needs in terms of channel mapping and needs as voiced by community members? What kinds of communication strategies and solutions are developed by those at the margins? I will sort of wrap up within the next minute so that we can have some time for question and answer. So this is sort of the last example I want to use. This is an example of a community radio that is developed by a local community station of women, once again, working on a project of local health and healing. In this context, what they did with the community radio is using radio as a site to tell stories of the positive community health resources in the community. So for instance, in many indigenous communities in India, they protect the trees because the trees are also medicinal. Yeah, you think about many of our modern medicines like malaria, where does it come from? A lot of it comes from indigenous knowledge and indigenous ways of knowing, right? So in this case, the women farmers, the women say that we are going to respect these trees and protect these as medicinal and health and healing resources and protect the traditions that we have had in our community of health and healing knowledge. So once they do that, they think about communication then as creating spaces for listening. Meaning challenging, for instance, the dominant stories of biomedicine by local stories of health and healing that has been passed down through many generations. Community voices that have hitherto been erased create discursive spaces and discursive processes. Structural norms that privilege dominant social actors and their agendas of information dissemination and persuasion are challenged. Listening becomes a strategy for resistance to top-down intervention, attending closely to the articulations of local communities and community voices. So, as I wrap up my talk, I want to highlight 3 points. One, that when we think about inequalities that we witness across the globe today, we have to pay attention to communicative inequalities. The idea that there are unequal access to communication. But not only in terms of communicative inequalities as communication as an information resource, but more fundamentally as communication as a space for listening, as a space for voice, as a space for community storytelling. That's the first point. The second point is, let's start paying attention to the kinds of discourses that we are not listening to when we are talking about health and well-being. Let's start thinking about the boxes that constrain us. You know, in health communication, for instance, you can make a career becoming a cancer expert, right? Promoting fruits and vegetables, and that can be your career. What are the kinds of things you're blinded to, you're not seeing when you're that narrowly focused on something, and that do not allow you to see health and well-being more broadly? And thirdly, I hope that the conversation that you're having is so inspiring and inviting that when we think about creating community spaces as commons, what really is at question and what is really being threatened in terms of the commons? Surely, communicative commons is one way to think about it, but there are also other elements of the commons that seem to be at threat today by the corporate power structures and by the ways in which universities, our public spheres are being corporatized today. So how can these strategies of corporatization and consolidation of wealth be resisted as well through your community structures remains an important question. Thank you.
Thank you very much. We have time for a few questions and answers. If anyone wants to raise your hand, I'll bring the microphone so you'll be able to speak. Who has a question? Professor Dutta. No one? Surely. It's a pretty provocative talk, so surely there's something to talk about.
I'm just wondering if you have an opinion about whether using the computer or the internet resources for reaching community members?
Great question. Based on the literature that I have access to at my work, I would think that it really depends on the community and the context. Meaning that for the examples that I presented here, face-to-face seems to be the way. So your very classic age-old examples of peer leaders and community workers, you cannot bypass those communication channels. Now, what role do computers and technology play within that context? To me, it seems like you take sort of the e-health and e-democracy movement, for instance, in India. That's been a major initiative, and most projects have failed. So that's the first thing. But of, say, the 100 projects, there are 3 to 4 that have succeeded and worked well. And if you sort of look at, what are the kinds of patterns and trends you see with those 3 to 4 projects, what you see is they were not trying to substitute the technology for the community, but rather to build the technology into the community as a complementary or a supplementary resource, meaning that you still have your health worker and you still have your community worker, but the technology also worked as an interface for securing additional kinds of resources, additional kinds of information that could be taken out and then delivered and worked through with the health workers and community workers. So some kind of exploration of complementary relationships among many channels. So the broad idea that I'm suggesting is that maybe when you think about new media or new technologies, one has to think about the entire communication infrastructure, and then really consider how one particular technology might or might not fit in that infrastructure, but that has to come from within the community, from listening to the community voices.
You have another question?
Just real quickly, I was wondering if you could elaborate on what you meant in Africa with regard to the World Health Organization and how that perhaps impacted the public health own foundation for providing, or the government's rather, foundation for providing public health in the country?
Great question. So the World Health Organization and the World Bank worked collaboratively started in the late 1980s to introduce a series of structural adjustment reforms across multiple African countries, including countries in West Africa, where they suggested that the way to deliver better healthcare is to privatize. So what subsequently happened is that a number of social welfare and social benefits programs that were available to the poor, pretty much free of cost, became privatized entities that were now being delivered through private service providers who had profit logics that were attached to it. In that process then, many of the public health infrastructure started receiving less and less resources. So if you look at Sierra Leone as one example, you see that hospitals in Sierra Leone had shortages of staff, shortages of medical beds, and actually these shortages, meaning that the number of beds and the number of staff that are available now are lesser than they were in the early 1980s. So these directed and specific privatization programs were directed at turning healthcare into a site of profiteering. So what I'm saying is that this is exactly what led to the lack of health infrastructure capacity to serve the needs of the people that needed healthcare and that didn't have the money to pay for it. As a result of which, the health solutions moved toward quarantining, right? So we are going to take the patients and take the sick ones and try to quarantine them rather than to healing and treating. So if you talk about the human rights abuses and the fundamental threat to human dignity that is brought about by this model of privatization, I think that is enormous and needs to be, and it's the elephant that in the room that's not being talked about.
Maybe this is a similar question, but I hear one of your solutions is to empower communities, allow communities to do their own work. And the other is, if you're doing primary prevention, is to work on the structures, the larger structures. So, you know, how do you work with World Health and the UN and the, you know, state of Indiana, for God's sake, excuse me, but, you know, we're no longer the Mississippi of the Midwest. We are Mississippi, you know. And so how do you affect change? How do we, as these people working in the Commons or wanting to work in the Commons, affect change on those higher policy levels?
What a great question, and a really challenging one at that too. I think I'm going to suggest 3 layers of this. The first is that as part of the community and listening to community voices, to create those spaces for listening, but also to connect those spaces with more national level and global level conversations. I think that's an important point. So what you find with the stories of these women farmers, so you talk about disenfranchisement in terms of access, this is a very disenfranchised community, and the way they were able to enact change is by creating not only spaces from within the community, but also finding ways of connecting these spaces with other similar spaces. So I think that solidarity is a key part of finding that collaboration, finding that networks of collaboration that can work together. So in that sense, you know, when you talk about the work you're doing in Bloomington, I see immediately the value of connecting this with the work that is happening, say, in Gary, or the work that is happening in Indianapolis, and finding networks that way, right? But of course, as I say this, and that's why I said this is complex, because I also recognize that there are powerful political actors and powerful corporate actors that operate with different kinds of logics within these very communities, and and sometimes the agendas and interests are at cross purposes, meaning that you might have a particular health agenda, but that might not fit the economic agenda of the city or of the state. So one of the things that I think comes out of this work is also recognizing how to leverage resources. Meaning, you know, when we work with the Northwest Indiana Health Disparities Initiative, we spent a lot of time leveraging relationships and building relationships with the Black Caucus and with political leaders and with the mayor's office, right? But then connecting that thread with the broader health disparities initiatives across the US. And seeing how those stories can connect and map out with each other. And finally, I would suggest, you know, the third element being, and of course, you know, different communities do this in different ways. One has to find the cultural ways meaningful ways of doing it. But to me, it seems that, you know, we often talk about 2 elements. One is reform. How much are we going to reform the structures? But the other is resistance and direct action. And in some ways, the kinds of problems that we are facing in the world today calls for resistance and direct action. And I think the question that then does become, how does one appropriately and meaningfully think about resistance and direct action within these contexts and within the struggles that we are trying to work on? You know, so Fedra briefly talked about the work we are doing with foreign domestic workers with Singapore, and we began there with a very simple project, what does health mean to you? And of course, initially we had multiple civil society organizations that felt comfortable working on this because they thought it was going to be about telling domestic workers to eat healthy and exercise and all of these things, right? But pretty soon, because it was organic and because we put emphasis on listening to community voices, they themselves came up with the idea of labor rights and the notion that violation of labor rights of domestic workers counts as trafficking. So we never imagined this, but we ended up then working on a campaign, a large-scale national campaign on changing the definition of trafficking in Southeast Asia from just sex trafficking, which is how we tried to think about it as this exotic entity, to labor trafficking, which is much more common, and which includes things like, promising your domestic worker $500 and paying her $200, or not giving her day off. So these became sites of labor activism and of resistance, but I think resistance in a way that also is culturally understanding of the cultural norms and the structural norms and works within those. So, that's why I don't think I can have a blanket solution, but rather that it has to come from within those community initiatives.
I think that was a perfect question and answer to wrap up this session. Those of you who are participating in the conference or the community meeting that Joe Ponglinton has set up, please reconvene back in the Grand Japani room when you can get there. In the meantime, I'd like to have everyone thank us again for thank you very much.